Low back extension in standing and low back extension in prone or lying on one's stomach are both lumbar spine joint extension or backward bending, but they're different loads. And the point I want to make today is that that load often matters. Not always, but you'll see patients that do well with lumbar extension in prone, for example, but not see any benefit to the standing version, and vice versa. And you'll see some people that do equally well with both. And of course, for the patients that lumbar extension is not the directional preference, they will not get better or they'll get worse with lumbar extension. It's not just the low back for which the load matters. Knee movements, shoulder movements, all of those can be individualized to the load that works best for the patient. I'm not seeing a ton of adding weight bearing for shoulder exercises to change the load, but we can change the position. Sometimes, like shoulder internal rotation, we can do it in standing up the back, or you can do it in side lying where you do shoulder internal rotation in that direction. There's more weight bearing through the lower extremities to be considered. For example, you can do knee extension in supine with no weight bearing, no load, or you can do knee extension with considerable or full body weight load through it in standing. So when I think of orthopedics, I have that 4-step hierarchy of location, diagnosis, direction, and force. And load is right in there between direction and force. Maybe I'll add it to that kind of hierarchy at some point, but it is really important. Think about the direction first. Once you have that, is it lumbar extension or flexion or side glide or what have you? Then we consider the load. Standing, supine, prone, seated, whatever option you have, and then the amount of force. Patient overpressure, or more with a belt, or more with a clinician, hands, etc. So do not be completely dismissive of a movement if that one particular load is not fruitful. Of course, if that movement in that direction with that load, with that amount of force is making someone worse, it might be a time to change the load, but it might be a time to change the direction. The algorithm for understanding a patient's response to a repeated movement test is a bit complex, and I've gone over it a little bit in other videos, but that's what clinicians spend months, years, decades getting good at, is understanding how the patient's response to one specific movement, knee flexion and standing, for example, or lumbar extension and prone, how the patient responds to that dictates where we think we need to go next to get to the most fruitful exercise, if there is one, as fast as possible. I find for most patients, at least 70% of orthopedic disorders, there is a specific movement that will resolve signs and symptoms. But that movement is delineated by the location first, find out if it's in the affected joint or somewhere else in the body that's causing another joint or another part of the body to have symptoms and signs. Then in this case, the diagnosis would be a mechanical joint derangement if it responds to a specific movement. Then we get into the direction, extension, flexion, etc., load, and then the amount of force. So don't forget the load when you're considering the tests that you do, and don't forget about the load when you consider what could be fruitful treatment.